This is part 2 of the 2-part episode on BPH, or benign prostatic hyperplasia, or enlarged prostate. Today, again, I have Dr. Marks with us. Thanks for joining me. His esteemed colleague, Concord Urology, and board-certified urologist. And let's pick it up where we left off. You know, we talked, to recap for the audience, part 1, we talked about dietary, behavioral modification, you know, what prostate enlargement is, as well as medical management. And I think that's where a lot of primary care providers could do a lot of that work. And then now we get to the urologic, you know, it's all urology, but where we really, as surgeons, can chime in. So let's just jump into it. You know, hopefully the audience will have seen part 1, get a break, you know, maybe to use the bathroom, and then come back for part 2. So let's start about that quote-unquote index patient. So the guy that's in your office has had tamsulosin usage, maybe finasteride, tried it for a year, is listed as having incontinence or some voiding dysfunction, and is in your clinic. Give me a flavor of what types of things you would do to work up that patient, and then we'll take it from there.
Absolutely. Great to be back. I think that the man who clearly has an enlarged prostate but has some of these other bladder symptoms such as incontinence, you really want to first make sure, are you on the right pathway? Is this definitely a prostate issue? A couple ways to determine that are really sort of based on the exam, based on their symptoms, but maybe some additional diagnostic testing is sometimes warranted. It's not always necessary, but it may be warranted if the picture's a little bit more confusing. So is their stream of urine slow? You know, and that's a subjective question. Some people say, yeah, it's always been slow. No, it's been normal. It's normal. But normal for you may be pretty darn slow for someone else. So how do you gauge that? There's a simple office test that sometimes provides a little information. That's called a uroflow test. It's basically peeing into a special funnel or toilet that measures the speed of flow. If we find that the speed is really reduced compared to, say, the average of the same sort of age-matched group of people, you might say, okay, really slow stream, lots of symptoms, probably a prostate, go ahead and maybe treat it surgically if that is where all the problem is. But sometimes it's still a little confusing, and if you really want to know for sure, is this a bladder problem, is this a prostate problem, there is a more advanced diagnostic test called urodynamics. It's a special test that we do in the office that involves a very small catheter, maybe about the size of a piece of spaghetti, that goes in through the urethra, or the tube where the urine comes from, through the prostate and up into the bladder. And another small one the same size that goes into the rectum, and we measure the pressures through those catheters between the two spaces. We then fill up your bladder with a fluid that's visible on some x-rays to try to see how does the bladder look when it's expanding, and then to measure the pressures. Those little catheters have pressure recorders at the end. So we can see, are there bladder muscle spasms? Is that the reason why you're having bladder incontinence? And at what pressure does your bladder empty? If there's a very high pressure required to empty your bladder and the flow is very slow, then it really points to an obstructed bladder. And if the prostate is enlarged on physical exam, or visually enlarged if we look in with a special procedure called cystoscopy, which is a catheter that has a camera on it, a little chip that we can see into the prostate, one would say, it seems like you've failed medical management of your prostate disorder. It's time to treat the prostate. This is where we bring it right back to you.
Oh, exactly.
Because that's your
field
of expertise.
Thing, man. Thanks. Sorry, I was so excited. I think I jumped in before you finished, but this could be the trademark for the whole series. We're bringing it back to the prostate. But good points on the urodynamics, and I think just with your specialty in female pelvic medicine and reconstructive surgery, urodynamics, I mean, if my bag is the prostate and love is, you know, laser prostate surgery in men's health, the urodynamics, you know, that's when you get all, you know, technical with pressure flows and nomograms and everything. So that's why I'm so glad we've built this program in Concord, where we talk all the time together, share patients, and have that duality of experience. But one thing I wanted to extend from your discussion was the cystoscopy, or that catheter test where there's a camera. And I think it's not just something that we do in urology. I think, you know, plumbers inspect pipes with fiber optic cameras. I actually, in my neighborhood, saw the city of Concord with special machines and robots that can crawl around in the sewer pipes and look for blockages and whatnot. So same thing for the cystoscopy. So men and women, if there's any question about the structural aspect of the urinary system, we look inside, because I think that's a little bit off topic, but a young person, I think we talk about the prostate age group roughly being 50 plus in a man, but any 30-year-old man that gets sent over for quote unquote BPH, I'm looking for stricture. And I think that's where that structural assessment comes in. And I think certainly when it comes to someone that visually has obstruction, has uroflow testing or urodynamic evaluation that says that there's some obstruction, medications are refractory, we talk about surgical management. Thanks for the segue about doing outlet procedures or prostate opening procedures. It's just like a valve where if the prostate's growing, bladder is not happy, it's got to squeeze really hard against that outlet. We talk about surgeries to open up that prostate channel. The two main ones are a TURP or transurethral resection of the prostate, or a scraping of the prostate, and a newer technique called green light photovaporization, or other lasers that are out there. There's a lot of different products for that. I won't talk about the other newer techniques that are out there. I think just for the sake of completeness, we have minimally invasive surgeries or strut procedures that are newly available, but to kind of stick to the longest duration, more tried and true method, you're really talking about a TURP or a laser vaporization. But let me kick it back to you for a second, because I know in every urologist armamentarium is that TURP. I think American urology, I could spend a whole episode discussing how urology started in America. One could argue that a prostate procedure started urology in America. Let me have your thoughts on the TURP procedure for a bit, how it's done, what the pathway is, and I can probably pick it up for the laser part of it, and then we'll jump into what happens when we tame the prostate, but the bladders don't quite work the way we want them to afterward.
Absolutely. The transurethral resection of the prostate procedure, or the TURP, as you sort of put in common terms, is the roto-rooter of the prostate, is looking into the prostate through the urethra with a telescope or a very small catheter that has a camera on it. And on the edge of that camera, or on the end, is a working element, a tool that comes out of the end of that camera with a little bit of a wire. That wire is an electric wire. That wire is made to cut into the prostate itself, but from the inside. So we talk about different types of prostate surgery. When people are thinking prostate cancer, they're thinking of the outcomes of prostate cancer surgery, which is when the entire prostate is removed, sort of shell and all. Think about the prostate as a small fruit. We have a very small fruit with an outside skin or a peel around it. When we're talking about cancer surgery, the entire thing is removed. But we're not talking about that here. We're talking about a surgery for symptoms, for benign disease. So we're really just kind of taking the fruit and coring out the apple. If it's an apple, you're taking the core, you're coring out the apple, you're leaving the outside skin around it, and that's what holds all those important nerves and blood vessels. So we're basically opening up the channel physically by cutting with an electric type knife the pieces out. It's been around for decades. It's very tried and true, was considered the gold standard for the longest time in moderately sized prostates. That being said, there are some limitations. Those limitations were blood loss, which happened to be a little bit higher sometimes for very large prostates, sometimes needing a blood transfusion, sometimes requiring a staged procedure because the prostate was so big you couldn't do it in one sitting, but also requires a catheter afterwards and an overnight hospitalization to flush the bladder out with a sterile saline fluid so that blood clots don't form while the prostate's still kind of healing and bleeding. And for some men, it was a longer return to work, a longer stay in the hospital, and that was somewhat inconvenient. And so we thought, well, there must be some better technology out there, and that's where I think lasers became the new tool to check out, and maybe now even the tool of choice. I think we have some longer data that you can even start talking about.
Sure.
Well, what's the data? How do we know it's as good? Is it as good?
Well, it absolutely is. In fact, we have national data from the American College of Surgeons. They have a national quality database, and the complications are less with laser surgery, reoperation rate, blood transfusions, stuff like that. But I can't stress enough, and these are techniques. It's almost like saying a scalpel makes you a better or worse surgeon, is that these are tools. And I'm always very careful about trying to tout a technology too much, in the sense that a TURP and a master resectionist, master old school urologist, we have plenty in our group that are facile, just as good an outcome. I think you're still never going to get beyond the fact that you're using an electrocautery loop rather than a laser that can seal the tissue. But I would say that these are a TURP or that Roto-Rooter is definitely well within the standard. It's accepted. It's the gold standard, what people are gauged against. The laser surgery is, instead of using a scraper, using a laser fiber with a photo vaporizing device that can precisely tune to the tissue and essentially vaporize it. And as it cauterizes and resects that tissue, leaves behind, I don't want to say char in a bad way, but just really cooking it so that those blood vessels don't bleed, you don't get the ooze. In most cases, and the nice thing about our practice is that we all have our little superpower, in the sense that I kind of joke about our practice like we're like the Super Friends or the Justice League of America. So, you know, you've got sling powers, I've got laser powers, but having done almost 500 of these, 95% of patients can go home the same day, obviously appropriately selected. Like I said, we're not saying this all comers. Anyone can get a great operation from a surgeon that does the TURP, but in my hands here at Concord Hospital, you know, great outcomes for the right people. And I think in the end, getting people home, you know, home sooner from the hospital, avoiding the in hospitalized setting, home, less bleeding, back to work. I think that for my patient population in the men's health clinic, it works great. To get it back to where the bladder comes in, I do tell patients, and we do share that experience, that I think we try to be as upfront and honest with these people, saying you've got a lot of symptoms, and one tool that can be used to illustrate your symptoms would be an AUA symptom score. And I encourage anyone that has access to that on the internet, go look online and even print one out and take a look at it yourself. Or there's some apps that have been created. I have an app out there called Bladder Pal and Prostate Pal. It's completely free. So Concord TV, Chris, you're going to be, this is kosher, okay? I'm not selling anything. It's free to the public for the common good. No call to action. It's all legit. But you can track your symptoms that way. But we're honest. We say, listen, we're going to take care of the drain at the outlet. Once we take care of that outlet, a lot of people do get relief. And that's why we study them ahead of time. We do those tests you described. But in the person where, you know what, a lot of it's better, but they're still plagued, urgency, frequency, unfortunately still have some leakage. You know, where do we go next with that? You know, I think that what's great about the quote-unquote Justice League of America you know, analogy is that once they get the laser work done and we see how they're doing, we have that complexity in our practice that we share these people, and you grab me or I grab you and I'll say, hey, you know, Dr. Marks, I opened this guy up. He's doing a lot better, but boy, he still wets himself 3 times at night and he gets up 3 times. What do we offer a guy like that still has lingering symptoms?
I think it's important to think about it in 2 different problems, right? You have a prostate problem, and then it may have created a bladder problem. The question is, will that bladder problem get better? The best thing we have on our hand is time. If you look at the medical literature, there's good data to show that at least 30 to 50% of these men with the urge symptoms, the incontinence symptoms, actually get better between that 3 to 6 month mark after prostate surgery. So I think first you got to give them time. That being said, you don't want to be miserable for 6 months. So at this point, adding in some of those medications we talked about to bridge that gap is very important, those overactive bladder type medications. But once we get beyond 6 months, we got to ask ourselves, are things going to get any better than they are? There may have been some remodeling of the bladder tissue because of that long-standing blockage. The tissues have changed. They've become more scarred, more fibrous. The muscle cells get thickened, and that leads to the bladder spasm symptoms, the urgency, and some of that may not get better. We've seen that in animal models and data that has been shown in laboratory animals when they block their bladders out. So we start thinking about the roadmap to treatment of these overactive bladder symptoms. And the first changes we've talked about last episode, the dietary changes, the behavioral changes, frequent voiding, make sure you're empty. Then come the medications. And when that no longer works, we start getting into options that are beyond medication, some of them procedural. Before we get onto those procedural options, we want to make sure that everything else looks okay. Have they healed from the prostate? Do they have a residual blockage because some scar tissue is formed? So you may need another repeat diagnostic test at this point just to make sure that we're on the right track. That may be that cystoscopy procedure. Or if you hadn't had urodynamics prior to your prostate procedure, and some men don't, you might want to consider that next. Then we start talking about these options for the bad bladder symptoms that won't go away. And those options kind of fall into 2 categories, basically. That first category is nerve modulation or neuromodulation. That is, how can we make the nerves that either go to or come from the bladder respond differently so that we're not sensing that urge or that we're not firing a signal back to the bladder saying time to go and the bladder spasms. So neuromodulation is putting an electrical signal next to one of the nerves of the bladder or to a nerve that transmits back to some bladder sensory place. So this is either something called sacral neuromodulation, which is a small little wire electrode that goes into the sacrum or the tailbone. It doesn't go into the spine. It's not into the spinal space. So it goes next to the spine in the area of the tailbone where the nerves from the spine come out to the bladder. That's a two-phase process where we test to see if you're a responder. Some men are responders and some aren't. Through that test phase, we could determine if that little battery, it's almost like a pacemaker, would go under the skin of the buttocks to see if that's going to be your solution. The other way to do nerve modulation or nerve retraining is called peripheral tibial nerve stimulation. This is where there's a nerve kind of on the back of the ankle that travels all the way up the back of the leg and goes to the same spinal cord center that the bladder nerves come from. And by stimulating that nerve for about 20 minutes once a week for 12 weeks in a row, we may be able to generate that same sort of response. The problem with that form of nerve modulation is it may not be sustainable, meaning once you stop those treatments, the symptoms may come back. So you may need return visits in order to kind of continue the therapy. That can be sometimes an inconvenience to patients. The second category of treatment is injection of a paralytic agent into the bladder. This paralytic agent is called onobotulinum toxin A. I'm going to try to stay away from brand names, but it's very common in cosmetic procedures.
It's the same stuff that you'd put in your face.
And it's the same stuff that you'd put in your face. We're not trying to take the wrinkles out of your bladder. We are trying to paralyze those muscles in the bladder in order to make the spasms no longer coordinated and to stop the spasms. That's a procedure that's done with the camera, the cystoscope, once again. It can be done in an office setting, or we can do it under some sedation in an operating room setting. The issues with that are, one, a high dose of that medication may make your bladder not empty completely. It could make you retain urine, and this can be a problem in people whose bladders don't function well enough. You'd have to consider cathing. But some people might say, I'd rather put a catheter in my bladder 4 times a day than wear 6 Depends if that was the only option. So it's a trade-off. It's a balance. The other problem with that medication is it doesn't last forever. It eventually, the proteins that it's made of kind of go away, they denature, and the effects of the medication will wear off. In the low dose used for treating these symptoms, we see about half of the people start having a return of symptoms at 3 months, and by 6 months, at least 2/3 to more will have symptoms that return. So we kind of start talking about repeat injections every 6 to 9 months.
So I'm glad it's a great overview of all the different options. I think the interesting thing to bring up is that no matter what your pathology, we have a solution for you.
Absolutely.
Between the two, and I think we always tailor this to the patient. I think Dr. Marks gave a very broad overview of the different types of treatment just to indicate the breadth, and I think a lot of it depends on patient preference. Some patients have a good enough outcome, still have some symptoms, but I always tell the patients, we don't live with the symptoms, the man does, and if the man feels like their quality of life is poor, by all means, we do the initial troubleshooting that you described where we look in the bladder and possibly do urodynamics, and then go to these different options. And I think there are a lot of men that could benefit from these adjunctive things. One topic I thought that was very interesting, and this is a good place for us to kind of jam on, is that before medical management, and we're talking about the alpha blockers and the 5-alpha reductase inhibitors, the medications we talked about more on the last episode, but alluded to this episode, is that there are a lot of people that just don't get prostate surgery anymore. And it used to be the case before these medications, if you had a problem, you get a TERP. You had a problem, you get a TERP. You had a problem, you get a TERP. And this is the X factor, and I think the urologic community is struggling with this, is that if you have a man that's been on medical management for umpteen years and has failed and gets that bladder outlet procedure, TERP or a green light photovaporization or some outlet procedure, what happens to that bladder? And I'm curious to see your thoughts about that, where the bladder community is, I guess. I know where the prostate community is in the sense that we're saying maybe the pendulum sprung way too far. We talk about collagen deposition, smooth muscle, not happy. Any thoughts on your end about that bladder end of it?
Yeah, absolutely. I think you hit the nail on the head right there, is that the surgical procedures for the prostate are probably underutilized now compared to the past where maybe they were overutilized, but we really have had the pendulum swing completely to the opposite direction. At this point, we see men who have failed multiple medications over the course of time, and we know that only a certain percentage of men are going to be a responder to these medications. And so what is the risk of delaying adequate treatment of a blocked outlet, a blocked prostate? And the collagen deposition is not necessarily reversible. So what we end up with is a bladder that may have a poor ability to squeeze or contract and empty. So we get bladders that don't empty completely because now they're weak. I compare this to heart failure. You have high blood pressure that's not treated for many, many years. It puts so much strain on the heart dilates, right? The heart expands, the muscle becomes weaker. Now it can't squeeze all the way to empty all the blood out. You get congestive heart failure. This is bladder failure. Bladder failure from high pressure urination over many, many years. And sometimes these symptoms are so subtle, they kind of sneak up on you. Definitely, we see the elderly gentleman who comes in who really kind of had mild symptoms forever and ever. It was never really treated. And all of a sudden they come in and they can't pee. And it's really because their bladder's not able to squeeze enough. So now you got a problem where the bladder's not strong enough, but the prostate's still blocked. It's a difficult situation to get to. And I think that comes back to you. What do you tell those men who really have bladder failure but are still blocked from your prostate? How can we help those folks?
I'm glad you brought that up. I never say no to the patients, meaning that some patients and families want their quote-unquote day in court. So as you've alluded to, and it kind of brings over to what are the complications of untreated prostate enlargement. And one of the complications is the bladder just doesn't work. I always tell patients and families that we'll take it to testing. We say, let's do some urodynamic evaluations. This is bladder function, because if the family really, really wants it, the patient really wants treatment, although the bladder is somewhat compromised, you don't know. And sometimes I say, if you understand the risks of it, the benefits of it, that I can't promise you that with your bladder function that I could guarantee a catheter-free existence, let's give it a shot, because until you open up that bladder outlet, you just don't know. And I've seen surprising outcomes where I wasn't quite sure it would work out, but the family and patient really, really want to go for it. And there's great outcomes, and unfortunately vice versa, because like we talked about, you over medically treat, and we're not saying go rush out and just get surgery directly, but we just don't know what happens over long-standing blockage. And it's much like the heart failure. I think one thing that we should probably think about ourselves is that I've never really thought as much about that heart analogy, and I love it, is that maybe urinary retention is the heart attack of the urinary system, right?
Absolutely.
So that you have that muscle failure. It can't overcome that obstruction from the prostate, and it just poops out. And I think that tips over to several other things. And we talked more about it as a urinary function of going out to pee out in the greens and nighttime stuff, and maybe more of a quality of life thing. And that's definitely true. But you've highlighted the fact that prostate enlargement could be a life-threatening disease, meaning that urinary retention, urinary tract infections, bladder stones or stone development, renal kidney failure, backing up into the kidneys are real problems. So it's kind of tongue-in-cheek, a lot of these things about the prostate as far as symptoms, but real problems for which in our practice I think we have ample modalities to treat. So thanks a lot for the time today after our hard work day.
Absolutely. It's great to be here. Great to be part of a wonderful community.